Hello, my name is Steve Hendrick. I'm a partner with Curi Advisory, and today I would like to walk through analyzing physician compensation trends, taking a data-driven approach to be as efficient as possible. So the agenda for the webinar today will be defining the challenge, pinpointing the issue, learning from other practices, and considering a new solution that may be more efficient for you. About Curi Advisory, we're a data-driven, human-inspired business solutions. We combine a practice analytics platform with a group of operators who offer consulting on an as-needed basis. And we believe the combination of technology without ops experience or ops without data to work from, neither one are complete as when you have them together. So that's what we bring our clients and help them leverage their data to make, again, informed business decisions. So physician comp, we've all been there, right? We get anybody that's managed a group of physicians, you've had to deal with this. It's not unique to docs, it's really any partnership, but obviously healthcare is our space. So I'm sure you've all gotten similar questions. Why did my comp go down this month? Why does Dr. Smith's comp seem to be trending higher than mine for the last month, quarter, year, et cetera, and we're the same specialty or we work in the same office? Should I be seeing more patients to make up for lost compensation last month? Can you speak to the billing team about working my accounts? Everybody always wants to go straight to the rev cycle team when many times it's not there. That's not where the answer is. Can you tell me what my comp's going to be for the rest of this year? Those are all a lot of the types of questions that you get hit with that you need to be able to respond to the shareholder physicians or even the employed physicians. So you try to dig into the data to answer those questions. You ask 21 questions, you run a variety of reports that you have to try to dump to Excel or piece together. You check your rev cycle billing reports, you compare them, you ask questions. It still isn't, you still haven't quite figured out where it's at. And so the vicious cycle repeats itself while at the same time you're managing the day-to-day activity of the practice, and you get hit with and interrupted with these other things that take priority on a day-to-day basis. Everything from we got patients arguing in the waiting room. What do I do? Dr. Smith's upset with the new MA. It says it's slowing them down. How do you want me to handle that? The refrigerator in the break room just broke. Who do you want me to call to fix it? Receptionist isn't able to come in today. Who can we pull to work patient check-in? So, we understand that it is a very busy, rapidly changing environment that you're trying to manage a day-to-day while still working on strategic or analytical issues. So pinpointing the issue for us, this is the process that we follow, that we have found most useful in troubleshooting to identify if there is an issue and where it is. Start with, is it impacting all the docs in your practice? If it's not, is it a particular geographic location? Something's going on with this location versus our other 3 locations. Or is it a subspecialty or a group? It's only impacting our spine physicians if you're an ortho group versus our hip and knee physicians. Or is it just an individual provider level? It really is down to that individual doc level. So reviewing probable causes. Well, for us, there's really 3 probable causes or 3 areas. One is provider productivity changes, provider utilization changes, or rev cycle issues. And again, everybody wants to go straight to rev cycle. And unless you have known issues in your rev billing and collection and rev cycle processes, it's typically not there. Because if you've got a broken process or a problem there, it's going to expose itself across many docs or the majority of docs. So from a provider productivity changes, the key performance indicators that we look at to determine what could be driving it are declining office sessions, changes in new and established patient ratios, fewer patients per office session, or fewer patients per surgical session if you're a surgical practice. You've declining surgical sessions, right? Is an issue. If you're not getting those new patients in the door, you don't have enough patients that need surgery, and maybe you're losing one of your surgical sessions. The other is ancillary yield. So what's your office visit to ancillary ratio? Are there some discrepancies there? Do you have leakage where certain docs are referring more of the ancillary stuff out, or most of the time they're just not being as intentional about educating the patient and about being able to get the ancillary service from within the practice and referring internally. And then labor costs are not aligned to productivity changes, right? So if your volume has gone down, or you've got one less surgical session or office session, et cetera, you need to adjust those labor costs because they do, again, they're variable and they do align and impact that the physician comp. The second area are provider utilization changes. So this is things like increase in time it takes for patients to get appointments. So we've saw an increase in wait times or access times, and kind of what's driving that. If you're not getting the patients in, there certainly can't be seen, and the charges and payments and revenue is not going to come in. Significant decreases in wait times or market demand changes. So going the other way, if you're not monitoring your access or wait times, and you're seeing that go down, that obviously is going to impact your volumes. Increase in no-show appointments, an increase in same-day cancel appointments, and most practice management systems will have a report about no-shows, and you can track that. But very few, if any, actually give you the ability to define and track same-day canceled appointments. And those are just as impactful as no-shows. And a lot of times practices don't have visibility to that. Decreased patient sat with the office, decreased patient satisfaction with the provider. If you're not monitoring that, those things could impact, patients choosing a particular office or physician, which obviously bleeds through all the way through to the physician's compensation. Payer mix changes related to external referrals, and again, ancillary leakage that we've already talked about. And then rev cycle issues. These are the most common. Everybody looks at these, or they should be. Time of service collection issues. Is that going up or down? Have you seen some changes there that are impacting the rev cycle? Increased missing tickets. Again, believe it or not, you still see a lot of practices where you've got tickets are not turned in. The doc will start the note in the EMR. The patient has arrived. They start the note, but maybe they don't complete it. And until they complete it, those charges are not going to be passed over to the billing system to file the claim or send that patient statement. Are there changes in coding, undercoding compared to bell curve trends? Changes in AR days or AR aging. Hey, we're starting to see an increase in the days in AR. Increase in denials. Is there something going on in denials? Payer mix shift for those office or surgical visits. Are we seeing some shifts there that we need to understand and pay attention to? And then decrease in charges per office or surgical encounter, and decreases in revenue per office or surgical encounter. And there's multiple things that can cause both of those. And it's not just in the billing office. These are things that the rev cycle starts all the way out at the front desk as soon as the patient initiates contact with the practice. Okay, but finding time to analyze all that is still a very big challenge. The ideal process would be to leverage real-time data and reporting to help you identify the issues, not after the doc comes and asks the question. You fix the issue, you remediate it or act on it, and then you continue to monitor. Well, that one loop has to be repeated many times across many fronts when you're managing a busy physician practice on a daily basis. So, what have some other practices, our clients, how have they leveraged the data to help them in this regard? So a couple of case studies that I'll share. The first one is from an orthopedic practice who had downtown specialty centers whose subspecialists would rotate out to the community locations to fill specialty needs. So they may not have enough demand to put a foot and ankle surgeon or a spine surgeon out in the community clinics. And so they would rotate from the downtown subspecialty centers. They would rotate out 1 or 2 or 3 days a week to fill that specialty need until there was enough volume to justify putting that particular specialty in the practice. Well, one of their spine physicians who did rotate out to 2 community clinics as well as the downtown spine center asked why their compensation had started declining. So it's a great question. Let's drill into it. The first thing we looked at is help the client analyze is it all physicians or just the spine section? It was just spine. Is it all the spine physicians or just the individual who raised it? In this case, it was just the one doc. Was that physician's sessions work down? No, they're consistent. Is the physician's new patient volume down? Nope, that wasn't it. Is the physician's patients per office and surgical session down? No, they had maintained the same volume, so no changes there. Were there any changes in the billing and collections performance? Nope, everything was consistent there. Had the physician's payer mix changed? Yes, but interestingly, only at one of the 3 locations that the doc saw patients at. And so what we saw at that one location is that physician's Medicaid and self-pay percentage from a payer mix perspective shot up from 4%, which was his overall average, to 35%. Wow, what caused that sudden shift? Well, in digging into it, we drilled down and identified that it was coming from a particular referral pattern from a hospital-employed primary care group. Lo and behold, the hospital had acquired a competing neurospine practice, a small practice in just that local market. And once acquired, they closed that practice to Medicaid and self-pay patients and told the hospital-employed primary care practices to send all those patients with the best payers to the newly acquired specialty practice and send the less desirable payers to our client. Client leadership pulled all the referring data to show that this was isolated to that market, to just that one physician, to just the referrals that they were getting from the primary care. And in this particular client is in a market where the vast majority of primary care docs are employed by the health systems. So they pulled all the data, we helped them prep it, and then they met with the local hospital CEO to share the information and call them out for cherry picking patients because they had philosophically stated that they weren't going to do that, and they didn't do it, and they expected all physicians, to take all patients, and we're not living up to that themselves. So what was the result? Referral patterns immediately corrected back to the historical percentages that they used to be. And the client used this information to not only correct, but improve their market share in that market. And then the health system leadership learned that our client monitors everything, and they haven't tried redirecting patients away from them to their employed competitors again. The second case study comes in slightly different context, but still very applicable for independent specialty practices on 4 different practice management systems merged into an aggregated practice. And it took them a year to consolidate onto a consistent standard practice management system post-merger. So the 4 divisions engaged us to help them with their comp modeling and some of the other merger activity. Division 1 had a physician comp model that was working effectively and it was completely compliant. Division 2, their comp model had to be completely redesigned to be START compliant. Division 3 needed a new model had to be constructed. The former lead physician was doing all the calculations and it didn't tie back to the GL or the financials, nor was it compliant. And then Division 4, a new model had to be constructed to be START compliant. So what's the new current state? The practice has the ability to view all the productivity charges, payments, AR, and other physician KPIs that impact compensation via the platform, our Arrowlytics platform. And then using the platform, we modeled different scenarios to help the practices determine and adopt a standard and compliant comp model across all 4 divisions. And then their MSO is developing, we're working with them to help them develop an automated platform to perform the comp calculations on a go-forward basis. So the result, compensation is now understood by all the docs in the practice. It's done to comply with STARK. The comp model is performed on time, and the physicians and their managers have access to the platform to go and look at KPIs that most directly impact comp on a daily, weekly, monthly basis if they would like. So considering a new solution, as I referenced earlier, is our Arrowlytics platform, and it pulls practice data from disparate sources into one system, providing kind of total practice insight and uncovering real-time opportunities for optimization. It has an online reputation management and marketing component combined with the key performance indicators to drive practice optimization and growth. And then our team has consultative insights and support if and when needed to help our clients. So the platform is designed to really do 3 things: drive new patient volume, help the practice increase margin per patient, and that comes from not doing more services per patient, but making sure that all the services that are needed and performed get billed and collected for, and that the practice has visibility to all the practice assets to increase the efficient use of all those assets. And those assets are the physicians, any APPs, your ancillary services, your revenue generating clinic space, your staff, etc. And we feel like if we do those 2 things, help those practices do those 2 things, and then we have optional consulting support if and when the practice needs it, it will lead to helping the practice optimize its financial performance. So what are some of these KPIs? These are just a few that we look at for provider productivity. Sessions worked year over year, new and established visits year over year, office visits per session year over year, office visits per session by month. A lot of times with docs, they forget that last year their family vacation was was in May, not June. And so when they get their May financials and they see that their comp's down, they immediately go to, something's wrong, the billing office, et cetera, especially if you have a well-performing billing and collection shop and your days in AR are less than 30. If a physician takes the first week of the month off, they're going to fill it in their compensation by the end of the month. And so sometimes they forget, and rather than send off a bunch of emails and have people in the billing shop running a bunch of reports to defend themselves, we start by looking at the provider's practice patterns and make sure there's no discrepancies there. So that's the office visits by session. And then we look at surgical yield. Is there something going on that the ratio of surgical patients to new patients is changing? And what's driving that? Is it the types of patients that the doc is seeing? Have they started doing some new procedures that are taken away from maybe some of the volume from some of the older procedures that they had been doing prior to electing to start these new ones. And then we look at things like arrived patient per clinical support FTE, x-ray procedures per rad tech, total appointments per appointment scheduler, and then tests and surgeries per test and surgery scheduling FTE. And then for the for an orthopedic practice, which is the one we're using this data from, what is their physical therapy and MRI yield? And that looks across all providers. And comparing them, benchmarking to similar docs with similar subspecialties, similar stage of career to, again, identify your outliers. So moving to the next is provider utilization KPIs. So what are some of those that we utilize to determine what's going on with physician comp? Increase in time for patients to get appointments. Again, we've already talked about that. Is the wait time or the access to get in, is that growing? And if it is, that's a bad problem if you're in a competitive market. So you've got to figure out how to create more capacity to get those patients in. Significant decreases in wait times or market demand changes, again, going in the opposite direction. Increase in no-shows, same-day cancels, patient sat with the office, patient satisfaction with the provider. Are there call center issues? Are there external provider referral pattern changes? Well, that was certainly what we saw with the one previous case study. Payer mix changes related to those external referrals, same thing. And then ancillary utilization and leakage. If it isn't in one of those two areas, then we check rev cycle. And again, you're looking for things like time of service collections in the office, surgical pre-collections, ancillary pre-collections, missing tickets, charge posting lag times, your established versus new. Is your ratio of established to new patient visits what it should be, or has the physician's practice gotten so busy that as the surgical volume picked up, those established and post-op follow-ups are eaten into the new patient slots, which will, of course, have a dilutive effect on the practice. So strategies around maintaining or increasing that new patient volume, but still seeing the established and post-ops in a timely manner. The other is AR days, AR over 20, the aging we talked about, payer mix by visit type. So sometimes payer mix changes are not universal. Sometimes it could be more on a particular visit type than another. And then what's your revenue per encounter and your charges per encounter? And that's for new, established, and surgical for both of those KPIs. So that kind of concludes the presentation for today and some of the KPIs and methodology that we help our clients with. If anyone has any questions, we would love to speak to you and share any of our experiences, answer any questions that you may have. My contact information is on the screen, so please feel free to reach out. And thank you for your time today.